Hello, everyone. I hope all of you are doing well. Today we'll be reading about imaging of congenital renal lesions. Right. So we'll first start with the embryology. Whenever we start any topic, I suggest all of you to just read the basic embryology so that you get an idea of what we are going to read in the future sessions. Right. So today I was given the opportunity to present the imaging in pediatric renal masses, but I thought that I'll first cover the congenital renal lesions. And it is just the spectrum of this that the last part is the pediatric renal masses, which will be covered in the next session. So today, whatever you are going to read or you are going to see actually, it is more of your what you are going to see in your routine practice and not much important for your exam point of view, right? But this is much more common than the renal masses that you will come across. And that is why I think these are actually more important for your routine and daily work. And by the end of this session, I'll be sharing some of my own cases so that you will get to know that all these are not rare things that I'm telling you. And mostly you will be able to diagnose all these conditions after the lecture is over. Right. So embryology, we all know that we are reading about the renal lesions. So this is the genitourinary system. It develops from the intermediate mesoderm and it comprises of the pro, meso, and the metanephros, right? It is from the 5th week onwards that the definite kidney becomes to form. So we have this cloaca, right, which gives rise to the bladder as well as the urethra. And we have this mesonephric duct, right? So the pronephros actually gets resolved. And what we have is the mesonephros and the mesonephric duct. Right. So that is from where the genitourinary system develops. So it is always said in a unity that it is the genital and the urinary system, they develop together. So most of the times, whenever you find an anomaly in the genital system or in the urinary system, there is an associated anomaly in the other system. So please look at the kidneys whenever you find a ureteric anomaly or an anomaly in the uterus in the females or in the seminal vesicles, and vice versa. Whenever you see an anomaly in the renal, kindly look for if there is any associated genitourinary abnormality. Right. So coming to the development of the kidneys. So what do we know about the kidneys? We know that the kidneys actually develop in the pelvis, and as they ascend cranially, they tend to rotate internally 90 degrees, right? So the kidney is ascending upwards and slowly rotating internally, so that the pelvis of the kidney and normally faces anteriorly, but in its actual position, as we all know, the pelvis of the kidney faces medially, right? So what do we see? So this is the level of the bladder, right? And we see the kidneys lying here. So first of all, whenever you see that there is an ectopic kidney, you see that the arterial supply of the kidneys also changes as they ascend upwards, right? So the final location of the kidneys is approximately from the level of T12 to L2 level. Right. So at that level, the artery also arises. We can see the bilateral renal arteries, which arises just distal to the origin of the superior mesenteric artery. So what do we see is that whenever normally both the kidneys, they ascend separately, and there is no problem in ascent, right? So first of all, they have a supply from the area of the common iliac artery, and then as they ascend, they develop it from the descending aorta, right? So all this anatomical information is important, because whenever you find a kidney in an ectopic location, you should know that where do I have to see for its vascular pedicle, right? So if you find a pelvic kidney, you have to know, you must see that the vascular supply is actually arising from what location. Right. This anatomy is also very important, because we see in the cases of horseshoe kidney, what happens is that both the kidneys actually fuse in the midline, right? And this is the aorta. So as the kidneys tend to cranially rise, so what happens is the first artery they come across is the IMA, and that is why the isthmus of the horseshoe kidney, it lies just below the origin of the inferior mesenteric artery, because both the kidneys are actually joined in the midline, and that is why they get stuck actually at the level which is beneath the origin of the IMA, right? So that is how the embryology actually helps you whenever you try to understand why such pathology is occurring in a person. Right. So uh, now we understand how does the pelvic calyceal system develops, and it actually uh, basically forms in relation with the kidneys. Right. So the metanephros is responsible for the metanephric diverticulum forms, right? This is the mesonephric duct, right? And there is a stalk which is called as the metanephric diverticulum. So this metanephric diverticulum, which arises from the mesonephric duct, it basically invades the metanephric mass of the intermediate mesoderm. Right. So there is this basically separate tissue which forms the kidney, and the ureteric, the metanephric diverticulum actually comes in between. So you should know that the importance of this anatomy is that these two have a separate origin, right? The kidneys and the pelvic calyceal system have a separate origin, and you can see that once the pelvis forms, then the calyx is formed, and then the collecting tubules form, and finally the small collecting tubules form, right? So that is how the kidney forms. So kidney forms actually. So if the metanephric diverticulum is not available, then this what happens to this tissue of metanephric tissue that had to make the kidney. So it will not form, and it will not form, right? So both of them have to come together to form a normal kidney. If any of those, if the metanephros or the mesonephros is pathological, a normal kidney will not form, and we will see how it affects our pathology. Right. So once we come to the classification, what do we read about? We have to read about the abnormalities in the number of kidneys, which can include renal agenesis. We can have renal hyperplasia. We can have a supernumerary kidneys. Then there can be abnormality in the position of the kidneys, where there can be rotational anomalies as well as renal ectopias. Then we have to read about the abnormalities in the renal fusion. As I have discussed the horseshoe kidney, then there can be a variety of cross-fused ectopic kidneys. Uh, the abnormalities of the renal vasculature, we also have to read. And then abnormalities in structure. As you can see, then that we can have a prominent extra-renal pelvis, we can have a PUJ obstruction, we can have a cystic renal dysplasia, we can have pseudorenal masses, and at last we have the renal tumors. So we will be covering everything except the renal tumors today. So all of this is very common in clinical practice, and you should all know about the various abnormalities. This is not a very important exam question, but a very important practical point of view. Right. So coming to the role of imaging. So antenatal USG is very important. Why? Because most of these pathologies, they can be detected antenatally if we are doing a proper level 2 scan. So I would advise all of you that whenever you do any kind of obstetric scan at any age, kindly try to look at the kidneys if there is any abnormality, because it has implications for the mother, right? There can be a condition called as Porter syndrome, where there is oligohydramnios secondary to the kidney diseases. So we'll be covering that also. So antenatal ultrasound is actually that area where if we are careful, then all these pathologies we might not see in the children, right? So please be careful whenever you're doing the antenatal ultrasound. Then ultrasound as a general practice, we all follow. Ultrasound is mostly the first modality of choice that is taken up in children with any suspected renal pathology. If the patient has deranged KFT or any urinary problem, the ultrasound KUB is what they usually advise. And I would always suggest that whenever you do a ultrasound KUB, kindly include the genitourinary system in your examination. At least see the prostate and the seminal vesicles in the males, and see the uterus and the ovaries and the cervical canal and the vagina in the females, because the anomalies in both the systems are associated. Right. So with the ultrasound, it has almost replaced the IVP, which was earlier the most common investigation, which was used mostly in renal stones or in patients in children. It is most commonly used to detect with psychouretic reflux also. But today, what the clinical scenario is that ultrasound is always the first modality, and then we advise accordingly if IVP is needed or CT is needed or MR urography is needed. So earlier it was considered that IVP is the most important investigation, but that is not now. I think if anybody does not know what is IVP, it is intravenous urography. We actually give contrast, intravenous contrast, and we see the excretion um, of the contrast via the kidneys. And as the kidneys excrete the contrast, we see the opacification of the pelvic calyceal system, as well as the course of the ureters, as well as the bladder. Right. So next is the IVP. As I told you, we can see the calyceal anatomy, and we can differentiate between the unusual causes of ureteral obstruction and PUJ obstruction. Right. So so the third investigation that all of you should know is the voiding cystourethropy. So what does the voiding cystourethropy mean? Voiding cystourethropy is that, as the name suggests, the patient voids while we image the bladder and the urethra.